Now, it's not so much a staged approach. What I'd like is now an approach to the stage from Akash Mehta, Tom Glover, and Kaushiki Singh, who are our intestinal failure surgeon, radiologist, and research fellow, respectively. They're going to tell us about perineal hernias. On you go, Akash.
Thank you very much, Ian, and thanks for the kind introduction. Thank you to the organizing committee for inviting me and us here to speak about something which is quickly becoming one of my favorite things I know nothing about. That's my disclaimer for today. So I'm Akash Mehta, I'm one of the consultant surgeons here. I have an interest in intestinal failure and abdominal wall pathology. And for some reason, people then decided to start sending me perineal hernias, because obviously a hernia is a hernia. Mm-hmm. And because I know next to nothing about this, even though I dabble, I have got help and support from two of my colleagues here. We're going to do a joint presentation. So I've got Dr. Tom Glover here, one of our highly specialist GI radiologists, and Kaushiki Singh, one of our excellent research fellows, who has been working with myself and Elaine on a very exciting research project on perineal hernias. So I'm going to set the scene a little bit and going to go through what we think we know, which is very little. So I'll be done pretty quickly. Then we've got Tom speaking about radiological assessment of perineal hernias, and then Kaushiki giving probably the most important part of this talk, which is what is actually important to patients. So there are so many things unknown about perineal hernias. We don't know how to define them, which is a problem in and of itself. We don't know how to classify them. We probably don't really know that much about how often they actually occur. We think we know, being surgeons and being doctors, what impact it has on patient quality of life, but there's very little out there about what patients actually indicate about what's the impact on their quality of life. And we also don't really know how to prevent them or how to manage them. Alex mentioned something in his talk about if there's a multiplicity of options, probably means that there's no one good option. And that holds true for a lot of things, including perineal hernias. So Kaushiki here, as part of her research project, did a scoping literature review, looking mainly at definitions and classification systems for perineal hernias, but also looking at patient-reported symptoms, quality of life, and management techniques and incidents. And as you can see, there's a lot of case reports out there, a lot of case series out there. But if you look at what one would suggest to be high-quality papers, it's not a lot out there. Really. However, the commonest definition, which has been found, and if you put them all together, is a protrusion of intra-abdominal contents through a defect in the pelvic floor. And then if you look at, okay, fine, what does that mean in terms of radiology? The commonest definition is intra-abdominal contents descending beyond the pubococcygeal line at rest in a supine position, which is all well and good in patients who have both a coccyx and a pubis, which a lot of the patients who my esteemed colleagues operate don't end up having anymore. Classification, what is of course the primary perineal hernias, as in the non-postoperative ones. Those are not really the ones we're focusing on here. So the secondary ones after pelvic surgery, typically abdominoperineal excisions, exenteration, sacrectomies. And then you can further classify in those who had an initial mesh reconstruction and those who've not had any form of reconstruction other than just a primary closure of their pelvic floor and perineum. This is an interesting one. This came from the group in Exeter a few years ago, where they tried to have a go at a classification system for perineal, not necessarily perineal hernias, but perineal bulging. So you've got the no hernias, so everything is intact and everything is where it's supposed to be. Then you got anterior detachment of a mesh which was placed. You got mesh eventration, so where it's kind of given way, but not completely. And then you've got, not very helpfully, the classification of true hernia. But still, it doesn't really give you an idea of the different flavors or types or configurations of perineal hernias. And, as I'm showing you here, not all perineal hernias are created equal. I hope this works. Yes. So this is one perineal hernia. That's a perineal hernia. That meets the classification and the definition. That's great. This is also a perineal hernia. Is it the same as the first one? Probably not. And then, icing on the cake, this is also a perineal hernia, where a lot of small bowel has herniated through and climbed up the lumbar spine. It's all a perineal hernia. But does that mean that we should all look at them and think about them in the same way? Probably not. There's some literature as well about incidence, not a lot, but you know, the incidence varies wildly between less than 1% to 45%. And you could see that there's a certain correlation between whether a mesh reconstruction was used as in terms of preventing perineal hernias versus primary closure. And symptoms, again, in the literature are varied: bulging, perineal discomfort, urinary symptoms, bowel symptoms. Of course, you know, perineal skin changes are quite often the harbinger of doom. And, you know, in a lot of papers, the hernia became symptomatic within the first 12 months after the index operation. The other thing, of course, to consider is that patients will report a wide variety of symptoms, and will all of the symptoms actually be caused by the hernia per se, or by the fact that they've had a really big operation in the pelvis? Quality of life, 2 studies only, really, looking at quality of life, and lo and behold, the quality of life is worse in patients who have a symptomatic perineal hernia. It beggars belief. Now, the management. For those of you who thought that when they saw perineal hernias in the program that you can hear the answer here, I'm terribly sorry, you really are not. I'm just going to show you that there's a lot of management strategies out there, which again goes to show that probably there's not one which has worked perfectly. So you've got approaches varying from just perineal to just abdominal, and then you got open versus minimally invasive abdominal procedures, and then the combined approaches where you have a perineal and a transabdominal approach. So that's one there. And then, of course, what repair? So that's the approach. What about the repair? Primary repairs? Mesh repairs? What mesh do you place? Where do you place it? Is it a pelvic inlet problem? Is it a pelvic outlet problem? Is it both? Is it neither? And should you actually be using flaps in conjunction with the mesh or just on its own? And then, of course, actually in literature review, there's hardly any mention of non-operative strategies. Just like in abdominal wall hernias, not every hernia needs to be operated. Doesn't mean they shouldn't be managed. There were 85 papers describing operative repair of a perineal hernia, 77 with a mesh repair, but large variation in types and placement of the mesh. And then actually not even all the papers described hernia recurrences. If you look at probably a reasonably good overview of this is meta-analysis published a few years ago in surgery from the Cleveland Clinic team. And again, you could see a wide variety of different approaches, different meshes in different positions. And if we feel recurrence is an important outcome, then probably the best outcomes were achieved in the abdominal approaches with a mesh. But going to the details of that is nearly impossible because these are all case series and everything. So that's just to show you that we know very little about all of this. I'm now going to hand over to my colleague, Tom Glover, to speak about the radiological aspects.
Thanks, Akash. So really just to echo what Akash has already mentioned, imaging, similarly, there's not much evidence out there. We've obviously got CT, MRI that you'll all be used to. CT is really good for sort of visualization of the pelvic floor anatomy, looking at defects. You have the advantage of doing multiplanar reformatting. It's good for acute scenarios because occasionally sort of these appear in an acute setting, looking for other hernias and also sort of estimating loss of domain, obviously in the anterior abdominal wall setting, but I think that's an interesting area for future work in perineal hernias. Then you also have MRI and also MRI proctography. You have better soft tissue resolution compared to CT. You can identify, generally speaking, the exact site of defect. And you can also have perform what we call a volumetric space sequence, which is like a CT scan but on MRI. So again, you can sort of modify your planes accordingly to assess defects and hernias. And finally, also MRI proctography can be a useful tool, looking at the sort of dynamic sort of descent of hernias, looking at other pelvic floor disorders at the same time. This is just a quick example of an acute CT scan. So this patient had an ELAP, and you can see there highlighted on the left side, the arrows, that's the sort of the neck of the hernia, pinching those small bowel loops, and you can see the yellow asterisk is a dilated small bowel loop on that coronal image. On the right-hand side, you can see a sagittal image of the same patient there, showing the pinch of that perineal hernia. So CT good for that, to see where it is. MRI proctography, so it's pre and post straining. And you can see quite nicely that hernia anterior to the rectum is nicely delineated and descends on the dynamic sequence highlighted by the yellow asterisk. So when we're looking at the MRIs in particular, we're looking at a few anatomical landmarks. I'm just going to spend a moment just to review those quickly because we're kind of looking at that for the assessment of our perineal hernias. We're using the pubococcygeal line. I think that's a pragmatic sort of landmark to use. You can debate whether that's the right one or not, but it's reproducible. And in the middle of the screen, I'm just highlighting a few other bits of anatomy. So IS for ischial spine, important bony landmark, and the sort of most superior part of the pelvic floor. Attachment, the levator, the SLAM or the sacroligamentous muscle complex, and the obturator internus highlighted on the right-hand side of that image. Similarly, on the coronal, we've got the same sort of labeling just to show in a different plane. Why have I bothered to mention all that? Well, I'll come to that in a second. Now, as Akash alluded to before, it seems fairly straightforward when you've got a sacrum and a coccyx and a pubic symphysis. And you can take your pubococcygeal line, you can measure the apex of your hernia, you can see what's inside it, you can measure your sort of transverse component as we've got in the middle there, highlighted by the red dashed arrow, between the pelvic side walls. But what happens when you change the goalposts? They move. In our cohort of patients in particular, lots of things get chopped out, including muscles, bones, and so on. This is an example of a patient who had a sidewall clearance, a high sacrectomy, and an LC, so things like the SLAM highlighted by the yellow hashed line were removed. But the green arrow is showing where obturator internus was. That was also removed in this patient. And you can see, highlighted by the red asterisk, you've got some fat which is herniating out through the notch. Now, again, sort of debatable whether you call that perineal hernia, but it shows it quite nicely, the sort of distortion of the planes. On the right-hand side, you can see the sagittal image there. Similarly, this patient has had their obturator internus excised as part of their pelvic exenteration, had a distal sacrectomy, and so on. But you can see, highlighted by the arrows there, that you've got some small bowel loops poking out through that defect in the obturator there. This is actually the same as what Akash showed, but that's again an attempt at measuring where am I drawing my lines. This is an approximation. This patient's hernia measured in excess of 30 centimeters, like this patient sitting on a shoebox. And the green line, where do I draw that? There's no guidance on that. That's kind of best guess. And that's something hopefully will be sort of borne out in future research. This is just a final example to show, again, someone who's had a total pelvic exenteration, no bony excision. You can see that all those small bowel loops herniating anteriorly, sort of inferior to the penis, really big hernia. So with that, I'll just pass on to Kaushiki, who'll tell you a bit about the patient side of things.
Thank you. So we've designed a research study looking at patient symptoms from perineal hernia, the impact on their quality of life, and the patient priorities for management. So we've carried out semi-structured interviews in patients with a known postoperative perineal hernia, regardless of whether they've already had their hernia operated on or not. So we've advertised the study through patient forums such as Bowel Cancer UK and Colostomy UK, and also through social media and through the Pelvic Exenteration Nursing Network. I've also contacted patients at St. Mark's with a known hernia directly. So I've interviewed 15 patients so far, and I would like to present the preliminary results today. We're still doing data analysis in detail. So I spoke to 5 women and 10 men. The mean age was 66. They were all Caucasian, except for one who was of Sri Lankan origin. The map shows the layouts of where the patients all live. So they're mostly focused in London and the southeast, but there are a few from further afield, such as Northern Ireland and Manchester. So of these patients, 13 had had pelvic resections for cancer treatment, and 2 had had resections for IBD management. 4 had already had a perineal hernia repaired. I've got quotes from the patients up on the slides. So the only 2 symptoms in common across all the patients was perineal bulging and perineal discomfort. Experiences did vary, and some patients thought that their bowel habit or their urinary habit was impacted, but they weren't sure if the changes they noticed were purely because of the hernia or not. Looking at quality of life, so all of these patients had already made changes to their daily lives because of the extensive cancer or IBD surgery that they'd undergone. And they found that having a perineal hernia did not necessarily change how they went about their daily lives, but it did impact their leisure activities. So things like going on long walks, doing certain exercises, going on holiday were impacted, and embarrassment played a key feature, which affected the clothing choices that they made, and also whether or not they wanted to socialize with people outside of immediate family. They all shared a concern for the future because they were all aware that they'd already had major surgery, and none of them particularly wanted another operation, and were worried about how things may develop should their symptoms worsen and if they need an operation in the future. The main priority for management across all patients was to stay comfortable. They'd all tried support garments, and they all found that the support garments either didn't help or were too uncomfortable to be used long term. And again, expectations over an operation varied. So some were of the opinion that a perineal hernia is like a hernia anywhere else in the body. If you have it and if it can be operated on, it should be operated on. But most agreed that they really didn't want a major operation in an area where they'd already had major surgery, and were worried about ending up worse off than they are currently following an operation to repair the hernia. And so they opted for conservative, watchful waiting, still being fearful that in the future, should they need an operation, they will likely be older and therefore maybe less likely to recover from an operation. So this leads me to what was actually the main theme throughout the interviews, from diagnosis to management of these hernias, and that is uncertainty. So patients really struggled with getting a diagnosis, and they often had to go through their GPs and local hospitals before being referred to a tertiary centre where they were diagnosed. And even when diagnosed, it often took them several months before they reached the right doctor who was able to offer appropriate management advice. They were also quite frustrated about the inconsistent advice on offer, and they all felt that we weren't offering enough conservative advice, in that we weren't telling patients what they can do to prevent the hernia or what they can do to stop it worsening once it's happened. So this leads me on to our future plans for research. So we will be using the results of these interviews and the literature review to devise a questionnaire which will further look at symptoms and impact on quality of life. We'll distribute the questionnaire to our exenteration patients, and we'll also be analysing the CT and MRI scans of these patients postoperatively and preoperatively. At the moment, we're doing this at St. Mark's, and we're hoping to turn this into a multi-centre protocol, which we're developing at the moment. All of this will hopefully culminate in a modified Delphi consensus process and agreement on a clinically applicable and useful definition, classification system and core outcomes data set. Thank you very much.